for those kind words. Thank you, Dr. Muralidhar sir, for inviting me. Your academic prowess, we have learned about it during COVID times. It's been such a great honor to listen to your talks because it is all based on Indian data, which we don't get to know because most of us do not publish. But your programs which we have attended has been of so much of use to us. Respected Dr. Bharati ma'am, thank you so much for the invitation. Let's just go on to my talk on surgical site infections. How can you have some clarity when there is so much of confusion regarding this condition and the management? Because most of us give antibiotics right, left, and center. Many times it does not seem to help. So how do we go about managing and preventing these infections, and how do you manage when it happens? So actually, surgical site infections are called SSI. It is actually an infection that occurs after any surgery in the part of the body where the surgery took place. So a surgical infection is one where surgery has been done, and that should occur within 30 days of the surgery. Then it's called as surgical site infections. When you want to know the types of SSI, it can be a superficial infection, it can be a deep infection, or it can be an organ infection. Superficial infections are one where it involves the skin and the subcutaneous tissue. Deep infections are the ones where the fascia and the muscle is involved. Organ or space surgical site infections are one where organs and spaces other than the incision that was opened or manipulated are getting involved, like a pelvic infection when the uterus has been manipulated or treated. But you need to know the classes of surgical wounds because we need to prophylactically manage a surgical wound to prevent a surgical site infection. To know the classes, it can be a clean surgical wound, that is, it is totally uninfected. No inflammation is encountered whatsoever during the surgery. The respiratory, alimentary, genital, or the urinary tract are uninfected and they have not been entered during the surgery. Then it becomes a class 1 or a clean surgery. It becomes a clean, contaminated, or class 2 surgical wound if the operative wound is where the genital or the urinary tract has been entered under controlled conditions and without unusual contamination. And this is usually a hysterectomy or a cesarean section. Class 3 is a contaminated wound where you've got an open, fresh, accidental wound. And here there's a major break in the sterile technique during the surgery, or there's a gross spillage from the gastrointestinal tract. Then it becomes a class 3 contaminated surgery. The ones which is class 4 are the dirty infected wounds are the ones. And there's an old trauma and there's a retained devitalized tissue there, and it involves existing clinical infection or there's a perforated viscera. All this comes under class 3 surgical wound. So what are the risk factors for a surgical site infection? When the lady is obese, you've got a higher chance of having a surgical site infection. When there's an associated bacterial vaginosis, it can lead on to an infection. Prior history of wound infection, when she has suffered an infection of previous surgery. Suppose she has undergone a radical surgery like a Wertham's hysterectomy, or she's an uncontrolled diabetic, you have to be prepared for a surgical site infection. And if the blood loss is more than a liter during surgery, please be prepared for a surgical site infection. So what are the precautions you will take to prevent a surgical site infection? The most important thing is the patient has to have a preoperative bath with a soap. Hand washing is a cornerstone for preventing a surgical site infection of the surgeons involved. Antibiotic prophylaxis, which you follow in your center. You need to have a hospital infection protocol, which will be able to tell you what's going on in your wards and what you need to do to prevent further infections. You need to minimize the hospitalization of patient in the preoperative period. Hair removal by shaving should not be done. Ideal is by clipping the excess hair. Skin preparation before surgery is very crucial to prevent a surgical site infection, and vaginal cleansing is extremely important in gynec surgeries to prevent a surgical site infection. WHO in 2018 has to say about this preoperative bathing. It's a good clinical practice for patients to bath or shower prior to a surgery. Either a plain soap or an antimicrobial soap may be used for this purpose. Hand washing, according to WHO, can be done by the surgeon by scrubbing with either an antimicrobial soap and water or an alcohol-based hand rub before they don sterile gloves. Regarding the antibiotic prophylaxis, which you need to follow to prevent a surgical site infection, to remember that the pathogens which are involved in obstetrics and gynecological procedures are usually gram-negative bacilli. Enterococci may be involved, group E streptococci may be involved, anaerobes also form a important part of the type of pathogens which are involved in the infections during a gynec surgery. So your preoperative prophylaxis for this patient who is going to undergo surgery should be chosen on the basis of their effectiveness against the pathogens which may be involved in the infections after the surgery. And you have to choose the antibiotic depending on the pathogens you're going to encounter during the surgery rather than against every possible pathogen. Do not give a combination of 3-4 antibiotics, which is not going to help. You need to have to choose that single antibiotic which should be effective against that possible pathogen during that particular surgery you're going to plan. And remember that the skin flora, the staphylococcus, are the usual organisms which are involved in infection of various surgeries. So if you can choose a first generation cephalosporins which are effective against this in the form of a simple cephalexin, cephalolithin, cefuroxime, or cefazolin, it's quite enough because staph organisms will be taken care of by these first generation cephalosporins. But if the patient has got a history of anaphylaxis or urticaria after penicillin therapy, you need to choose a prophylaxis with vancomycin or clindamycin. And when do you give your perioperative prophylaxis with antibiotics? The first dose should be always given before the incision. Ideally is within half an hour to 1 hour before the incision. And this will ensure that the antimicrobial levels in the tissue are adequate and is maintained for the duration of procedures, because usually gynec surgeries do not last beyond 2 hours. The route should be an intravenous route, and you have to give a dose which should be the same as a therapy of an infection. Do not give a smaller dose. Give the same dose which you'll give when you're going to treat an infection for the prophylaxis also. And the duration is, you need not continue for more than 24 hours because various studies have demonstrated efficacy of this prophylaxis for actually 12 hours. Beyond that, you do not need a prophylaxis to prevent an infection. And whenever there have been short and long courses compared, the shorter course is proven equally effective. So just giving one dose, or suppose the patient's obese, you can add a second dose 6 hours after the surgery. You need not give it beyond that. Maximum you can give up to 24 hours. And remember that even a single dose is as effective as multiple doses, and prophylaxis after wound closure is usually unnecessary. A prolonged antibiotic prophylaxis is not only ineffective when you give it beyond 24 hours in reducing an infection, but actually it will increase the antimicrobial resistance of your center, and there's a risk of colitis due to Clostridium difficile when you give antibiotics for beyond 24 hours as a prophylactic dose. So, but you can give redoses. Second doses can be given if the patient has undergone a longer surgery. It is extended beyond 2 half-lives of the antibiotic, which is given as a prophylactic dose, or if there's been a blood loss of 1.5 liters during surgery, you may need to give a second dose. So these are the antibiotic prophylaxis for the different types of surgical wounds. Suppose it's a clean surgery or a class 1 surgery, just giving a single dose of cefuroxime or cephalexin is quite enough, and ideally you should give it as 2 grams. This will be effective against gram-positive cocci, which are the reasons for infections in clean surgery, Staph aureus or the coagulous negative staphylococcus. But suppose it's a clean contaminated surgery like a hysterectomy or class 2 surgery, you need to remember that the organisms now which will be involved are gram-negative bacilli and anaerobes along with staph. So you may need to give ceftriaxone, which will be more effective against gram-negative. Here also cefazolin is quite effective, or an ampicillin-sulbactam combination is also quite effective as an antibiotic prophylaxis. Regarding class 3 of contaminated surgeries, here the anaerobes will form a greater part of the infection. So hence you need to add metronidazole even for a first line. You have to give a prophylaxis with cefazolin plus metronidazole, or metronidazole can be combined with an aminoglycoside or a fluoroquinolone. Suppose it's a class 4 dirty infected surgical wound. Here you will have a mixture of organisms, gram-negative, anaerobes, along with gram-positive bacteria. So here, even for prophylaxis, you will need to add to cefazolin and metronidazole, ertapenem, meropenem, or along with clindamycin. And you may need to add aminoglycoside or aztreonam. Or you can have this cheaper combination, fluoroquinolone, metronidazole with aminoglycoside, so that you cover all gram-positive, gram-negative, and anaerobic organisms. Then you need to have a hospital infection protocol for your hospital, and that is, you need to have a guideline for prevention and control of infections. Should have an antimicrobial policy which works for your hospital. You should have a surveillance policy to find out the infections which are happening. There should be a pakka disinfection policy. Isolation policy should also be there when you have a patient with florid infection. And you have to have a policy for investigation when there's an outbreak of an infection in the wards. And regarding hair removal by clipping, actually you need not remove hair before gynec surgeries, but if it's absolutely necessary, you can use a clipper to remove. Shaving is strongly discouraged at all times, whether preoperatively or in the operating room. And what is the skin preparation you'll do before surgery? You can use an alcohol-based antiseptic solutions, which are based on chlorhexidine or povidone iodine, and that's for the surgical site skin preparation. And please remember, for a gynec surgery, vaginal cleansing is extremely important. When you cleanse a vagina with povidone iodine or chlorhexidine, compared to when you use saline or there's no cleansing done, there's a high chance of reduction of infection of the uterus, fevers, and infection of the surgical wound when the cleansing is done compared to when you do not cleanse the vagina. And they have found out that these benefits were present whether you use iodine-based, or povidone-based, or chlorhexidine-based solutions for cleansing of the vagina. It got a great benefit when women were in labor before cesarean. That is, going for an emergency cesarean section, you should actually cleanse the vagina before you take the patient for surgery. What about the perioperative precautions you will follow to prevent the surgical site infections? Always maintain adequate hemostasis. Do not leave large areas of necrotic tissue behind. Trim the pedicles when you're removing the organ. Closure of subcutaneous tissue is not advisable. And suppose there's a dirty wound, a delayed closure may be much better than the instant closure. Use a closed section drain for your subcutaneous wound or your surgical site rather than a gravity drain, which may not work so much. What about the other perioperative precautions? Maintain a normal body temperature during surgery. Maintain a normal volume of the patient. Intense perioperative blood glucose control is mandatory because a person who's not controlled for diabetes is going to have a florid infection later on. Use sterile, disposable, non-woven, or you can use reusable woven drapes, which actually autoclave well. There's no need to go for expensive plastic adhesive incised drapes with or without antimicrobial properties, as the pharma keeps on saying. But you can consider antimicrobial coated sutures in infected wounds. Use of wound protective devices in clean, contaminated and dirty surgeries can also be considered to prevent surgical site infections. What are the post-operative precautions you should follow to prevent an infection? You can use an aqueous PVP solution before closure in both clean and clean contaminated wounds for the incisional wound irrigation. You need not do an antibiotic irrigation, which was done in the olden days. A saline irrigation can be considered also to prevent an infection. Antimicrobial sealants, which are quite expensive, need not be used after surgical site skin preparation. And consider giving perioperative oxygenation to the patient in the form of 80% fraction of inspired oxygen during general anesthesia and in the immediate postoperative period for at least 2 to 6 hours, which will give more oxygen to the wound and prevent an infection later on. And there's something which can be used if you're in a big center. You can use a prophylactic negative pressure wound therapy. They can be used for primarily closed surgical incisions in high-risk wounds, like the contaminated wounds, for the purpose of prevention of SSI. Not of much use is double gloving. There's no point in donning two pairs of gloves and then removing and then closing the skin. Doesn't seem to help. Changing of surgical instruments for skin closure is also not of much efficacy. Laminar flow theaters are not mandatory to prevent surgical site infection. There's no need for advanced skin dressings to prevent infections. And when you've done a dressing for the patient, it can be removed after 48 hours after the surgery. And the patient needs to have a daily bath with chlorhexidine soap. Now, when we come to the treatment of infections, when it's happened in spite of all your precautionary methods, you need to remember superficial infection is one, where it happens within 30 days after the surgery. It will involve only the skin or the subcutaneous tissue. And you need at least one of this criteria to say that is a superficial SSI. That is, there should be a purulent drainage, which can be confirmed with the laboratory or not. But just a collection is quite okay. But the patient needs to have one of the following signs or symptoms, like pain or tenderness in the wound, localized swelling, redness or heat to say that it is infected. Or if there's no drainage, suppose you've isolated organisms from an aseptically obtained culture of the fluid or tissue, that also tells you that there's a superficial infection. So you need to know what is not superficial infection. A stitch abscess is not a superficial surgical site infection. It's just a minimal inflammation discharge confined to the points of suture penetration. Infection of an episiotomy is not a superficial infection, or a newborn circumcision site which is infected is also not a superficial SSI. Infected burn wound is not considered as SSI, and an incisional SSI which extends into the facial muscle becomes a deep incisional SSI and not a superficial surgical site infection. So how do you treat? You will always take a sample of the collection needs to be sent to the laboratory, and you have to find out the sensitivity of the organisms to the antibiotics. But don't stop treating the patient for the 48 hours until you get the report. You can give a cephalosporin, and extended spectrum penicillin or first generation cephalosporin is quite okay, or you can combine gentamicin with clindamycin. And usually these infections happen when it happens after 24 hours after surgery. It's usually due to gram-positive cocci and sometimes rarely by gram-negative cocci. So you need an antibiotic which will cover gram-positive cocci, gram-negative bacilli, and anaerobes also. So giving an extended spectrum penicillin or a first-generation cephalosporin until you get a culture report is quite fine. But remember, suppose infections happen 3 days after the surgery, you will need to add metronidazole because it will be usually because of anaerobic organisms. So according to ICMR, they've given 2 options for superficial infection. The first line is according to the piperacillin tazobactam 4.5 gram every 8th hourly, that is 3 times a day IV, or imipenem with cilastin 500 milligram every 6th hourly, or there's a cheaper combination, ceftriaxone 1 gram every 24 hours with metronidazole every 8th hourly 500 milligram. That should work for superficial surgical site infection until you get your culture report. Suppose there's an wound abscess which is superficially seen, you can incise and drain. And when you give antibiotics for superficial infections, you have to give parenteral antibiotics until the patient is afebrile or there's an obvious clinical improvement. And after 24 to 48 hours after the patient is improved, you can convert to oral antibiotic. But suppose there's no relief after giving antibiotics for 72 hours, you will need to do a reevaluation to find out what else is happening to so that the patient is not responding to antibiotic therapy. It is a deep SSI when it involves a deep soft tissues, that is the fascia and the muscle layers of the incision. Here also you will have a purulent drainage from the deep incision, but there should not be any organ involvement to say it is deep SSI. If there's an organ or a space involvement, that is a pelvic space is involved, it becomes an organ SSI. When it's not involved, it becomes a deep SSI where there's only the fascia and the muscle being involved. And how do you diagnose a deep SSI? There will be a spontaneous dehiscence of the wound, or you have deliberately opened the wound because the patient has got one of the following signs or symptoms, that is fever more than 38 degrees centigrade, has got localized pain or tenderness, then you will diagnose deep SSI. Or there's an abscess, or there's an infection involving the deep incision which you're checked with a direct examination, or during a reoperation, or by histopathological or radiological examination. Here also you will take the pus in a sterile wide mouth screw cap container, and suppose it's a deep-seated abscess, you need to take the pus in anaerobic vials also. Suppose a pus is not available, you need to take a deep swabbing of the wound, and the sample should be always taken from the depth of the wound or from the advancing edge, and you need to avoid contamination from the surrounding skin when you take the swabs. Treatment for a deep SSI is you should open the wound widely to allow drainage, remove all the necrotic tissue, evaluate the facial integrity. Daily dressing should be done with loose, wet to dry dressings with saline moistened gauze or dilute hydrogen peroxide. And if she's a diabetic, a strict control of diabetes is absolutely necessary. Antibiotics should be based on the lab report, but empirical antibiotics should be started before the report becomes available. And whatever antibiotic you give, please add antibiotics which will be effective against anaerobes like piperacillin tazobactam, metronidazole, or a carbamazepine. Suppose a patient has got a post-operative fever, how are you going to evaluate her? Not all fevers will be due to infection. You need to have a temperature which is more than 38 degrees centigrade or 100.4 degree Fahrenheit on two occasions, 6 hours apart, and that should happen 24 hours after the surgery. And when you have a fever, do not only think of a surgical site infection, assess for a urinary tract infection, pneumonia, pelvic infection, a deep vein thrombosis, intravascular catheter infection, and drug fever. And always look for surgical wound erythema, induration and or tenderness around the incision. Check the drain and check the IV line always. And the investigations which you need to do in post-operative fever is examination of the sites is mandatory, very, very important. A complete blood count, a urine analysis, a chest X-ray, and blood investigations will be for electrolytes, renal function test, and liver function test, and the rest as per need according to your examination. Post-operative fever, if you're given antibiotics empirically and you've not shown response even after 72 hours after you started therapy, review the history, do a physical examination of the abdomen as well as the vault. Imaging, you may need to do it again. You need to pick up a new area of consolidation with the chest X-ray if a pneumonia has happened later on. Ultrasound may be needed to check for any abscesses, and sometimes you may even need an abdominal and a pelvic CT scan. And you need to send for multiple cultures if you have put a central line and suppose there is pus from the wound. And the indications for a pelvic or an abdominal CT scan is, suppose you're suspecting a fluid collection or abscess, suppose you're suspecting a retained foreign body, or you're suspecting septic thrombophlebitis, you may need to go for a CT scan. So the differential diagnosis of a persistent post-operative fever which is not responding to your antibiotics may be an organ, space, surgical site infection, maybe a vaginal cuff cellulitis, maybe an infected vaginal cuff hematoma or an abscess, maybe a post-operative ovarian abscess, can be necrotizing fasciitis, and rarely it can be septic thrombophlebitis. Organ or a space SSI is one where the infection is happening within 30 days of a surgery, and it involves any part of the anatomy other than the incision, which has been opened or manipulated during their operation. And along with that, the patient needs to have a purulent drainage from a drain that is placed through a stab wound, or you're isolating organisms from the organ or space. And when you're culturing it, when you're finding out organisms, it becomes an organ or space SSI. And suppose there's an abscess in the organ, that also becomes organ or space surgical site infection. And an abscess can be identified by direct examination, or if you've done a resurgery for a fever, or by histopathological or radiological examination, you have to confirm there's an infection before you say it's an organ SSI. And what about cuff cellulitis, vaginal cuff cellulitis? The symptoms are quite late. It doesn't happen in the immediate post-operative period. Patients will have a low abdominal pain later in the, probably a week after surgery. They can have pelvic pain, back pain, fever, and abnormal vaginal discharge. And when you examine the vagina, you will see a cuff hyperemia, induration, and tenderness. You can see pus discharge. And usually remember, the organisms will be gram-positive, gram-negative aerobes, as well as anaerobes. Suppose it's an infective vaginal cuff because of a hematoma, or there's an abscess formation. The fever happens quite early in the post-operative period compared to a cellulitis. Here, the patient will have chills, pelvic pain, and rectal pressures because of the hematoma or abscess. And you can actually see a tender fluctuant mass near the cuff. But if it's not seen, you need to do a pelvic ultrasound or CT scan to confirm that it's a hematoma or abscess. And what about post-operative ovarian abscess? It can happen late in the post-operative period. Patient will manifest with fever and abdominal pain. And suppose there's a sudden increase in pain, remember it can be a rupture of the ovarian abscess, and that becomes a surgical emergency. And remember that's because of a recent follicle expulsion when you left the ovary behind, you're doing a hysterectomy, or there's a surgical trauma on the premenopausal patient, or you have done a probing of the ovary during the surgery and that has caused an abscess later on. And the commonest cause of infection in ovarian ovary is the anaerobe. And sometimes you may need to do a pelvic ultrasound or CT scan to confirm the diagnosis of ovarian abscess. Not sometimes, you will need to do a pelvic ultrasound or a CT to confirm the diagnosis of ovarian abscess. And how do you manage? You will give them meropenem, clindamycin or gentamicin with metronidazole. And suppose a persistent abscess which is not responding to the antibiotics, a drainage is needed, and that needs to be done by a CT or an ultrasound guided percutaneous drainage, or a colpotomy is needed. A closed section drain needs to be kept for continuous evacuation for the next 2 to 3 days to prevent a reoccurring of the abscess. And what about necrotizing fasciitis? It happens with the skin, fascia, and muscle. Usually it's because of mixed infection, but it can be a multi-drug resistant Staphylococcus aureus. It is a rapidly progressive condition. Pain and toxicity to the patient will be out of proportion. There will be development of cutaneous necrosis and hemorrhagic bullae on the skin. The wound edges will be purple or necrotic, and they'll have clinical signs of sepsis, and there's a viscous malodorous drainage from the wound site. And the first line therapy will be piperacillin tazobactam with vancomycin. Alternative can be carbamazepine, but if it's a resistant organism, vancomycin will need to be added always. What about septic thrombophlebitis? This is a diagnosis of exclusion. Post-operative patient is having fever. She's not responding to your parenteral antibiotic therapy. You have ruled out an abscess and a hematoma, but still she's having fever. It may be because of a thrombophlebitis, which is septic. There's a classic variety and an enigmatic variety. Classic variety is the one which happens 2 to 4 days after surgery. The patient will have fever, tachycardia, gastrointestinal distress, unilateral abdominal pain, and in 50% there may be a palpable abdominal cord due to acute thrombus formation. And the enigmatic SPT is one. The patient will seem to have a clinical improvement, but there will be temperature spikes. The patient will have tachycardia during the spikes. And the cause is because of small, diffusely scattered thrombi in the small pelvic vessels. And when you examine the patient, there'll be very minimal pelvic findings. You will need to do a CT scan or an MRI to confirm the diagnosis of thrombophlebitis. So how do you treat? You will need to add anticoagulation with heparin for at least 7 to 10 days. Meropenem should be given as a first line, 500 milligram to 1 gram IV ethali. Add clindamycin or gentamicin, and along with that, metronidazole should also be added. So the take-home messages for this talk will be: single dose first generation prophylaxis is enough for most of our obstetric and gynec surgeries. Do not go for higher antibiotics and cause more of resistance. And remember that SSI occurs in 1 to 5% of obstetric and gynec surgeries. Morbidly obese women will have a 2 to 4-fold increase in surgical site infections always. And in the first 2 days post-op, it's usually due to streptococcus. After 2 days, 48 hours after surgery, it's usually due to staph or a mixed aerobic anaerobic infection. And in the management of surgical site infection, please remember to send the wound discharge for a culture. And before the culture report is available, the combination you need to give is a clindamycin or gentamicin. It seems to work the best because the resistance has still not occurred. But if there's no response after 2 to 3 days, evaluate for wound infection, deep abscess, hematoma, septic thrombophlebitis or mastitis. And when you do a wound closure after infection is resolved, when there's an infection in the surgical site, you need to do the closure after the wound infection is totally resolved, which can be done surgically or by secondary tissue. You just leave it open, and then once the inflammation has subsided, then you can close the wound, which works much better. Thank you so much for a patient hearing, and these are my references. Thank you so much.
Murli, are you there? Thank you, Dr. Charmila, for that very elaborate and informative talk on surgical site infections. The house is open for questions. Dr. Murli, the chairperson, I think he's there. Charmila, I have a question.
Yes, ma'am.
You just mentioned that surgical site infections are within 30 days of the surgery. But of late, I don't know how many of you are experiencing this. Delayed, I mean, like almost after 6 to 8 weeks, and sometimes even up to 12 weeks, we are seeing certain of them coming with small, superficial sinus-like thing with serous. There's no purulent discharge, it's just a serosanguinous discharge, in a small, very superficial, and it fails to heal for a long time. And culture has proven negative. And many of my colleagues have also had this even in the surgical field. And we treat them like atypical mycobacteria or something like that. And sometimes treatment is very, very difficult. One sinus heals and then they come back with another pimple which opens up. And then this goes on for about 6 to 12 months sometimes. Have you undergone?
Yeah. I've seen it more commonly in laparoscopic surgeries.
Yeah, so
somehow compared to open surgeries, it seems to be more common in laparoscopic surgery. It's basically because the autoclaving of the laparoscopic instruments. Most of the time, they tend to leave it in that Sidex, which is not optimal time, and they keep on reusing the solution. So that may be one reason. But if autoclaved properly and still the infection happens, it is like when you put your trocar, sometimes we tend to slide. A more obese lady, instead of going straight, we sometimes slide, and we could have caused some injury which you have not noticed. And it may be a little bleeder there, and it collects. And I've seen these infections happening, like, as you said, 1.5 to 2 months after the surgery is over. Yes. And one patient.
Charmila, we have seen them even in cesarean sections.
Cesarean. Yeah, that's what we did this presentation in Vijayawada, and they presented a whole list of patients who were all having post-surgical site infections. And as the diagnosis is when it's within 30 days, but as you said, it's quite late also. But and we cannot give anti-TB therapy nowadays without informing the government and without a report of approved mycobacteria there.
No, so I don't treating them because if the culture also comes negative, there is no proof. It is some sort of an atypical mycobacteria. And
that's what the surgeons told us when we had these lab infections, that when you treat for like mycobacteria, it heals. But we have to do it under the it has to be under the counter. We can't do it without a report. We can't do that, and we get. But how many of us have proved that it's atypical mycobacteria before we say that it responds? Probably the antibiotic which we give for a mycobacteria is the one which does not have resistance in that center. So when you give that, probably it works. But we need to prove that the organism was there before we give. And I have a patient who had endometriosis. So we did a lab surgery for her, and 6 months after the surgery, she had a skin infection, and that was constantly there. And luckily during COVID, she conceived also. So I was very worried during a delivery because the baby was in breech. So I was wondering, like, if I do a cesarean, it's going to flare up. But you will not believe it, totally it is cleared now. We didn't do anything at all.
Yeah, I think women, what I generally do is I put them on probiotics. I don't need antibiotics, and ask them to clean it with absolute alcohol, like sterilium or something. We prescribe that, ask them to clean it, leave it, keep it dry, give them probiotics. And sometimes I do prescribe the streptomycin powder.
Okay.
What comes in the vial, you know. So I just ask them to sprinkle that powder, and I don't know, there's no evidence of mycobacteria, but it heals.
No, how we treated our patients was we left the wound open.
Yeah, we leave the wound
open, and we don't do any suturing at all. And take a culture, and you don't see any organism there. We tell them just to do daily dressings.
Yeah, that's what.
And most of the time, it may take a prolonged period of time, but it heals by secondary intention.
Yeah, definitely.
When you try to interfere and take sutures and all that, it keeps on flaring again and again. That's what we
no suturing. You just keep. So I would like the house to give the experience on this, because I see a few answers, questions in the chat box that many have had the same type of problems. So, and somebody wants to know what is the correct method of lab instrument sterilization.
That itself is a big topic. Every instrument, your camera, your scope, your optical light source, all that has to be sterilized very correctly, and the Karl stores themselves do not give us a correct technique of how to sterilize. So it depends on your experience, but as much as possible, use the optimum time and do not reuse those solutions. That's what I've seen in multi-speciality. They keep on using it for different, the theater nurse doesn't even bother, and you have those cross infections. So
take time, I think, in between.
You should have a protocol for yourself and maintain it.
45 minutes time to
minimum. And wash it properly before you take it on the table. Many times they just drip it in some water and just keep it off there. It has to be cleaned off. All that solution has to be cleaned off before you take it for. And that's what I keep on saying now. Going back to our old days of open surgery seem to be much safer than going for lab for every single thing. They think lab first, but I think this probably the open surgeries are much safer in the longer run. We do not see so much of skin side, but you said as in cesareans also. But the main in cesareans is you do a vaginal cleansing, Bharati, before you take up
that we are doing. My surgeons have seen it in appendicectomy wounds. They have come across that in appendicectomy, herniorrhaphy wounds.
Patient characteristics have changed, no? More of obesity, they are more stagnant, they do not walk as much as possible. All that is probably adding on, and they are not healthy before their surgeries.
Exactly.
Previously, it was just appendicectomy and with thin patient. Now it's like to dig into it to get that appendix. Surgeries also become more difficult, and we take a longer time because of obesity in the patients. That also may add on to the increased rate of infections.
Madam, could you please add on your experience?
Yeah, very excellent talk, Dr. Charmila. It was very clear cut. Every word was like very clear what to do and what not to do, and very clear take home messages. I think they can implement this back home for your practical tips in their day-to-day practice. what Dr. Bharti was saying, like wide, like when we have something like necrotizing fasciitis, did you have like that, Bharti, or it was just?
Oh, no, madam, not necrotizing.
Simple, madam. It will be only clean. It will look clean.
Just as clear and the superficial skin, just punched out ulcer-like thing. It is very superficial. And the skin is thick out. There is some serious discharge, then it closes. Then one more where the mini prick site, it opens up there. This is after almost 3 months, 6 months. There's a varied presentation. They come
sometimes even the suture is not absorbed.
Absorbed also.
So that acts as a point where we have repeated sinuses, repeated.
Madam, even without sutures, it keeps on performing as blebs, small cuts.
Those are seen in obese patients. Yes, very rarely they are seen in obese patients. Obese patients. And sometimes even vicryl, sometimes it's not absorbed in some patients, that creates problem, not just prolene. It's absorbable sutures. For some people, it really takes some time. It depends from person to individual. And in those patients we have, then as you told, little bit dressing, all those things, over a period, it gets solved. We have seen some case of necrotizing fasciitis.
Yeah, that's horrible
to whatever you exercise, sometimes we have exercise from GP sternum to the wound for a penicillin incision. You can't imagine the way we have to go on exercising, and for that wound to heal, it's a real nightmare. Though they survived with lots of morbidity, months together, this thing, a very horrible thing, necrotizing fasciitis. But nowadays they are less. But in the past, I used to see lots of necrotizing fasciitis.
The main thing is, as you said, the preparation with betadine, abdomen or vagina, and the preoperative prophylactic antibiotic, and postoperative, of course, the other hygiene asepsis measures. And as Dr. Charmila said, just a single dose is very often sufficient if, of course, your OT is well maintained.
And regarding thrombophlebitis, in this group of I've seen lots of patients who are obese, and when they undergo laparoscopic surgery, it's better if you give heparin always in the post-operative period.
Because we follow that protocol.
And because when you put a suture or put a pedicle, that is when you tie it up, it doesn't seem to cause so much problem. But when you use a vessel sealer and then close off those vessels, there seems to be a higher risk of thrombophlebitis. So it's better if you give heparin.
Comorbidities and obesity, I think you have to give
for every comorbidities there you give heparin, but even if they're thin, but they have undergone a big surgery with lots of diathermy used, it's better if you go for heparin, because even thin patients I've seen collapsing with DVT after the surgery.
Yes, excellent.
Good evening.
Good evening.
I'm Dr. Durga Das. Charmila, it was an excellent presentation.
Thank you, sir.
I have some inputs and questions, sir.
Yes, sir.
First of all, the question was about regarding the SSI after which occurs after 3 months or 1.5 months, which we too had. Mostly it occurs in, as you're told, in the laparoscopic surgery. While we had some consecutively 4-5 times, we called the microbiologist. Then we found that one is ETO sterilization is much better than side X. Right? Because as you have told rightly, so many times we repeatedly use that side X. That's the one thing we have seen. Second thing, of what we have seen, is mycobacterial tuberculosis are harboring in water. So we changed the whole water line from the source tank. It exclusively for only operation theatre, labor room, and minor operation theatre. And it's only for that, and you put the disinfectant solution or those machines and all, supplying only to the OT and labor room and minor OT, wherein you require the real sepsis. As you are rightly told, Mycobacterium tuberculosis is the one thing we have to see. Even what Dr. Bharti told, that blebs coming after 1.5 months, it has stopped after the whole scenario of changing the water line. Coming to the hospital is different, and coming to these sectors are different. And we put the this thing antiseptic run through these 3 places. And because these Mycobacterium tuberculosis are waterborne. So that's the one thing. That's the reason we see after 45 days or 3 months. And this is the one thing regarding the discussions which were going on. So many things I wanted to ask you. Meantime, one thing, NDVH is the most common surgery. Do you suggest any vaginal tablet 3 days before surgery or something of that, sir?
It doesn't seem to help. So doesn't seem to help.
Okay, okay. What about the pre-op timing of antibiotic in cesarean and hysterectomy?
Within 1 hour, like a half an hour to 1 hour of your surgery, you need to give antibiotic, not before.
No, do you see after delivery of the baby in sections? Is it any relevance?
No, before the incision, you need to give your antibiotic, not before, not after that.
The incision.
Earlier, there was
And,
a concept
the baby may be affected. That's what many felt.
Yeah,
but
yeah. Earlier, there was a concept that in sections, though it's in hysterectomy, what you told 1 hour before, in sections you give after the delivery of the baby.
No, before.
Concept. Yeah,
before the incision, you need to give antibiotic. Otherwise, it doesn't work so much.
Yes, yes. Another thing I want to tell you about the MOPS. MOPS we use repeatedly by autoclaving.
You should not.
The threats that come, we dip in doing sections and the thing. The threats will be fallen off in the abdominal cavity. That may be so. It's a small things which this thing. Another thing, as you have rightly told, when we do hysterectomy for plenty of additions or endometriosis, at the end of surgery, we have a habit of washing the abdomen. No. After that, we pour. Yeah, washing we used to do. We used to pour metronidazole and leave.
Okay.
That, you have rightly told. It has been there's no use about that. Washing, I think, removes all the blood clots.
But that also is not necessary, sir. Actually, they say even if you leave that blood, it gets absorbed. And
you handle the better. The less you handle, the
less. And you may spread that infection if you wash it, and it may go through the entire peritoneal cavity. And, even in an ectopic pregnancy, do not do a washing at all. Many tend to do that. It's not necessary at all.
Preferably use disposable mops. Don't reuse mops.
You should use fresh mops always. And when you're doing a cesarean, many have got the habit of putting that mop inside and cleaning that uterine cavity. Never do that. When you do that, you're going to cause more of endometritis. That can cause a nidus for infection later on.
Just like a suction, you can do suction.
Suction, or you can put a finger and take off the membranes. A finger will be more than enough to remove the membranes.
And whatever the use of suture material for closure, do you prefer monofilament like PDS or Prolin, or multifilament like Vicryl?
So suppose
closing rectus, I'm asking.
Prolin is always better. Anytime Prolin is better. We don't have experience with PDS here, but Prolin we have very good experience. And
Prolin is better than Vicryl, you mean to say?
Yeah, I have not used. I don't use Vicryl much because I'm scared about that dehiscence which can happen. Theoretically, it may be, but still I prefer Prolin always. Okay. Because Vicryl causes more of inflammation also, so that can be a nidus for infection later. Prolin is quite it's a very non-inflammatory thing. It's not going to cause much of problems. And for
very rarely, Charmila, sorry, this Prolin, some of them develop that very knot.
That knot, this thing, but you can bury the knot when you're finishing. So it's
sometimes some of them develop a sinus.
It's a little rare. Because Vicryl, I'm little scared of always, because that integrity of Vicryl for a long period of time is not equal to Prolin. So somehow
but we have been routinely using Vicryl, and we have not seen any hernias or anything like that. A good response.
Yeah, we use Vicryl regularly because obviously it's a fasciitis incision. Integrity was okay, but my concern was about the monofilament and multifilament. The site of this thing. Multifilament, it's more prone for infection rather than monofilament.
Monofilament is better.
Yeah, monofilament is always better.
Always better.
In that respect, I was asking about Prolin.
Okay.
And in a morbidly obese patient, thick subcutaneous tissue, do you prefer to have a drainage, Romovac drainage?
You have a pakka hemostasis, close it with ethylon, single layer. Most of the times they will not have an infection later on.
Even subcutaneous tissue,
No, I don't close a subcutaneous tissue in morbidly obese. No, I don't.
That's what it is.
But a perfect hemostasis. Catch all those bleeders. Make sure that you do not bleed before you close this thing.
Thank you.
Okay, Dr. Charmila, the mere fact that you have generated so much of discussion, and it's been very, very useful discussion. I was quietly watching. I just want to share a couple of my experience. One as an intern.
Yes.
When I was posted to surgery, there was a patient, the surgery professor told me, Vijay Kansa told me, you have no other work in surgery now except daily dressing of this patient who had total opening of the abdominal wall. And believe me, as you, Charmila, correctly said, just the dressing will take care of it. At the end of the posting, after 1 month, there was a very good healing. The second is my experience as SHO, Senior House Officer in St. John's. I was not getting a job as Senior House Officer because it was always reserved for a lady and also that for a nun. A male was not acceptable. But Dr. Narayanan gave me an opportunity as a research assistant, and my research was putting Neosporin ointment and after the suturing before the dressing. And definitely that was my first paper also, which I published. There was some benefit. But later in life, I realized that, the topical ointments are not really that going to be helpful. A clean surgery is more than enough. And finally, when I was a PG, there was one teacher who used to have a habit of, after closing the rectus and before closing the skin, in between, she would just pour betadine. I used to get scared, but then she said, nothing will happen, don't worry. She never sutured the subcutaneous, as you said, but just pouring that. And that. So each person has his own or her own experience, but the bottom line is that we have to maintain the cleanliness at all levels, preoperative, intraoperative, and postoperative. Unnecessary interventions, as you correctly said, unnecessary washing, unnecessary mopping, and all these things will increase the infection rates. And what you said correctly is that the reason why the antibiotic has to be given before the incision is that at the time of incision, the blood levels of antibiotics should be highest. That is the reason. So thank you very much, Charmila, for a wonderful, useful, practical talk. I think next month we may not have Cpap because it coincides with AICOG Calcutta.
Yes, yeah.
I hope you approve that, Dr. Kasturi.
Yes, we'll have it next time. Yes, sure.